you a little bit about the beginnings of RAMSES, and like many things conceived in the back of a limousine, RAMSES was a little bit of an accident, but it was a good one, and I think we're kind of formed around a core value, which we feel like some people sort of under-recognize the utility of the surgical robot. It was sort of originally seen as kind of an advanced laparoscope. And I think everybody has sort of lived within that incremental advancement universe. And I think that what ties this group together is we looked at the precision capabilities of the robot, and we saw that as sort of the principal advantage in microsurgery. And there's really nothing more important than precision in microsurgery. So I think that's one of the things that's brought all this group together. And it's great to have lots of new people here. So this session is really about helping some of the new people figure out how to get their programs going. It's difficult to do. It's often a sob story. Sometimes it doesn't turn out well. We've lost lots of members of this group to attrition and an inability to move programs forward. So I'm going to just tell you a little bit about some of my thoughts about how to get a practice going and what it takes, and just give, it's especially geared towards people who are just starting out and trying to move things ahead in their institution. A lot of it's based on regulatory stuff that exists in the United States, but I think it's broadly applicable. So I'll kind of go forward. This is an overview of some of the topics I'm going to cover. Identification of a clinical need, skill acquisition, credentialing and regulatory stuff, cost. We'll talk a little bit about training and access, patient selection, and then ultimately dissemination of the technique, which is kind of the final stage of the evolution of this. I think this is a very important part. You don't want to walk around with a hammer looking for a nail. You really have to be quite careful about and honest about your needs assessment. What are you doing in your practice where you could take advantage of the things that a robot provides? And what are those things? Minimal access, precision, enhanced visualization. So you have to think about it that way to determine what you want to do with the robot and why. And everybody's practice is a little different. I'll tell you just a little bit about how my process evolved. I do transoral robotic reconstruction, I do robotic micro, and I do harvested muscle flaps. So those are the three things that have sort of emerged in my clinical practice as being needed. So just to kind of expound on that a little bit, the transoral robot is a lot of words. I'm sorry, this is not the sexiest talk in the group, but I'll show a lot of videos and stuff later. Towards essentially when I was a resident at Penn, there was a lot of transoral robotic surgery. That's where it started, and none of the defects were being reconstructed. I asked them why, and they said we don't have plastic surgeons who can reconstruct any of them, and so we just leave them open. So that, to me, was a fairly obvious invitation to get started, and that's how I got started in robotics. For robotic microsurgery, this was more of a theoretical thing, and I sort of mentioned it already. There are just simply limits to what human beings can do physiologically with their bodies and their hands, and those limitations just don't exist in robotics, either from the visualization or the dexterity perspective. And so that one emerged in my mind as important too. And then I was doing a lot of muscle flaps, which don't require skin as part of the flaps, but they do require long incisions for skin, for flap removal. And I felt that that was excessively morbid and it wasn't necessary. And so those were the three things that emerged as clinical needs in my practice. Skill acquisition is extremely important and often difficult to come by. I think it's important to partner with a robotics lab to develop the things that you're trying to do, unless you can find a mentor, which if you're pioneering is hard to do. You know, it's like a free climb. Somebody's got to lay the rope, and if it's you need to be sure that you know what you're doing. So this is what the process that I went through. I went through a dry lab, a wet lab, a cadaver lab, ultimately went bench to bedside, and now have a mature program. I'll just briefly show a couple of images of that process. I would really emphasize the need for in-skill acquisition to learn how to edit video. If a tree falls in the woods and nobody's there, it didn't happen. If it's not documented, it didn't happen. Nobody will believe you unless you can show that. So the best way to show people what you're doing is to show the video. Nobody wants to sit through 10 hours of videotape watching you painstakingly perform an operation, so you need to be able to show people what's happening. And so Video editing has really facilitated my ability to communicate what I'm doing, why it's important. This is my first patient. This is a Wawa. I don't know if you have Wawa here. I'm sure you don't. It's actually not outside of the northeast of the United States, but Wawa is a convenience store. This is a Wawa coffee cup. This is a Penrose drain with a little hole cut in it, and I was trying to simulate the oropharynx. So this is my first patient. This is just me trying to even figure out if I could do anything inside the mouth. This is the way I started. I then moved to a wet lab, which was a porcine model, basically doing the exact same thing, sewing in skin grafts at the base of the tongue and the posterior pharynx. I was a resident at this point still. I think the most important laboratory to be involved in, everybody always wants to go operate on the pig as a simulation for human surgery. I would say that the cadaver is the most important thing to work on in your procedure development. All of the ergonomics and setup that you're going to be doing is all going to be based on human anatomy. And the robotic techniques are very sensitive to setup. So I think it's very important to work on a cadaver. This is the mature state.
The patient who underwent a robotic resection.
So this is just a transoral reconstruction that I'm doing. I'll let the narration.
This is a cleft palate view, so the base of the tongue is up and the soft palate is down. Radioform flap has been placed into the oropharynx, and I'm performing a robotic inset. Once beyond the soft palate, due to line of sight issues and space restrictions, standard manual technique becomes very difficult. The robot provides excellent exposure and the ability to accurately place anti-suture in hard-to-reach areas. Precision here is important for two reasons. Unless a watertight closure is performed, a fistula is likely to result. And unless the pharynx is reconstructed anatomically and without redundancy, future speech and swallowing will be compromised. Economy of motion is critical because small movements at the tips of the instruments correspond to larger movements proximally, where the excursion of the arms is limited by the area within the mouth retractor. For this reason, setup of the arms in endoscope is also critical and very sensitive to error. So you may notice that as I get deeper,
so you get the idea of that. And that's now a mature practice, and it's relatively straightforward to do, but it requires a lot of work to get there. Micro was the same thing. It seems like it's going to be straightforward, but there's always things you don't predict. So this is the cadaver lab, just making sure that the camera is out of the way of the arms. There's lots of little things. This is now, mature and relatively straightforward.
Robotic microvascular anastomosis. The arteries shown here are between 2 and 3 millimeters, and I'm using 9/0 suture as you normally would. In my opinion, there are advantages and disadvantages to robotic microsurgery. The main advantage is precision. The robot is capable of up to 5-to-1 motion scaling, which means when you move 5 centimeters in the surgeon's console, the robot arms move 1 centimeter. Another advantage is 100% tremor elimination. The combination of motion scaling and tremor elimination greatly enhances precision, which is really what microsurgery is about. Last but not least is surgeon ergonomics. We ignore this to our own detriment, but it is in fact very important over the life of a microsurgeon and in any particular case. The robotic console is very ergonomic. The main disadvantage of robots in microsurgery is a lack of haptic or tactile feedback. Although I thought this would be a much bigger problem than it turns out to be, what many have learned is that in microsurgery, much of what we think we feel, we actually see, and our brains supply the illusion of sensation. That being said, the robot is very strong and you have to pay extra attention to visual cues, particularly when it comes to setting down the knot. You should try to minimize movement of the vessel while tying, because movement indicates a differential in applied force to one end of the suture or the other. One should only pull until the air in the knot disappears. These measures minimize vessel trauma and knot trauma, and this has not been a problem. Another disadvantage is the current instrumentation.
You get the idea. The latissimus, I spent the most time in the lab. This took me about 1.5 years before I ever got near a patient. There were so many small things with the setup, and I couldn't get it consistent. And so I really spent a lot of time applying for small grants, buying cadavers. This was all as a resident and fellow, so money is short, as you all know. But it was worth the investment, because once you get in there, it really eliminates a lot of the insecurity and uncertainty that you approach. And I think you get yourself off of the curve of human experimentation and onto the curve of medical practice. And I think that's an extremely important thing for patient care. It's just some images from the laboratory. And this allowed me to kind of quantify the appropriate location for the ports, which is really the most important and sensitive part for this operation. And this is just a quick video kind of showing what it looks like.
Latissimus dorsi flap. What you're seeing here is the dissection between the LD muscle, which is up, and the chest wall, which is down. The head is to the right of the screen, and the feet to the left. So this is a right muscle. I'm using a monopolar scissors for the dissection and a Cadier grasper, which is an atraumatic.
Each process from going from the lab into the operating room, it's a critical process. And some people are lucky enough to be in mature applications and have that as a part of their training pathway, and they can get graduated experience. That is not the case for the things that we're doing. Graduated experience is not possible unless you happen to be in one of those unique locations where these things are being practiced. And so I think it's very important to go through your own process of training. You have to train yourself. And the only way to do that is really get preclinical. And so that's why I emphasize the laboratory portion of the experience. How you guys doing over there? All right.
So Jesse, how much does it cost to do set up a cadaver lab? How much does it cost you to get sponsorship for that?
Well, these labs exist in various places around the country.
This is the harvest.
I'm just going to pass this video. You can include it to me now. You have to kind of identify them. So it's one at UCF or USF that you know about. Their Intuitive can tell you where their robots are in facilities. You've got to find one of these facilities. The problem now, and that leads me to kind of my next point a little bit, is that Intuitive is restricting access to these facilities based on your specialty. So if your specialty does not have 510K, that's an American device clearance designation. If your specialty does not have a 510K for a procedure, they will not either certify you or give you access to their lab. I happen to know the guy who runs the lab because I've been working with him for a decade. And I have to sort of push my way around with Intuitive a little bit. Last time I went in there, they told me I wasn't allowed to take any pictures, I couldn't do this, I couldn't do that. I always push back. You'll see as we talk a little bit more about this, there's a lot of pushing. There's no other way to get through because nobody wants you to do it. Nobody cares if you do it. Nobody wants you to do it. And lots of people don't want you to do it. So really not that many people on your side. The credentialing issue, I just mentioned Intuitive's scam is kind of that they give you a certification. They're one of the only device companies that actually certifies you to work on their product. They're not doctors. They don't know how to do surgery, but they feel that they can certify surgeons and train surgeons about doing surgery. They can't train us to do any of the things that we do with the robot because they don't know anything about it or anything about what we do. So whether they gave you a certificate or not, that only harms you in your ability to get into your own hospitals. So people may have that problem, and you have to really work with your local rep to get that certificate and to get trained. And I think one of the things RAMSES can do is advocate for our own certification by physicians, by people who are trained to take care of patients, not build machines. You may have your own institutional requirements. We have ours. You have to be proctored. I'm just going to keep going a little bit here, sorry. You have to be proctored for several cases and can then be credentialed. Most of the medical practice committees credential you based on application of privileges. For me, I just applied for privileges, I received them, and then I started doing cases. And sometimes you can sort of slip through that way, other times you'll run into some regulatory roadblocks. At the end of the day, you have to do your first case, and that's always a bit of a leap of faith. The regulatory environment is extremely fierce. The FDA is our version. You have the EC mark. If your FDA application, if your application is approved, such as TORS, you don't have an issue. Everything else is off-label. And so you're going to have a potential FDA problem. The question always arises, do you need an IRB? This really is a philosophical question about the difference between research and surgical innovation. If you are conducting prospective research, then you need an IRB. If what you're doing you consider part of your medical practice and is surgical innovation, then arguably you do not need an IRB. I've performed transplants without IRBs. I've done all of my robotic work so far without an IRB. Some people consider that a little bit of a fringe position. I believe this is surgical innovation, not medical research. If you are on an IRB, then you will need an investigational device exemption because the IRB will require one from the FDA. So if you go through the IRB, you will have to apply for that. That is a mountain of paperwork, but there are certain things, and I've done that process, there are certain things for which it has to happen. Now, cost is a big issue, and everybody kind of parades it around as the main obstacle. People really don't understand that there's a difference between the cost of buying a machine and the cost of using a machine. Joe, you're driving a Tesla, right? What's it cost? All right, well in the real world it costs whatever it costs, 75,000 bucks, 80,000 bucks. But what it costs us to drive every day is zero. Okay, so the hospital buys a robot based on a business plan to attract surgeons and patient volume. Once the robot is there, if it is not used, it is a waste of money. So when anybody asks you, oh, isn't it so much more expensive to do your robotic cases? What they're really asking is, what is the contribution margin of your case? And contribution margin is the revenue minus the cost. The revenue is your professional fee and the hospital technical fees. The costs are whatever the disposables for the devices are, minus your length of stay, minus OR time, and whatever complications you have. That's the equation, that's all there is to it. Your procedure might have a positive contribution margin, it might have a negative contribution margin. And that may apply differently to robotics. There are cost savings in robotics and in general in enhanced recovery. Gabe's going to talk about this at some point, but you can make the argument that when you reduce length of stay, you have better patient-reported outcomes, you have opioid-sparing protocols, that robotics, when involved in that type of formula, can save an institution money. But that's an argument that has to be made. This is a slide that Gabe gave me, and I'll just skip ahead a little bit because I can see Mincha over here waving me down for time. But this just shows the difference between a minimally invasive lobectomy and a VATS lobectomy, which is an open lobectomy versus a VATS lobectomy. The difference in the length of stays and the gross margin and then profit per year based on the reduced length of stay. And what you're seeing is a $2.2 million margin just based on reduced length of stay and enhanced recovery. Coincidentally, the price of a robot is $2.2 million. So, I mean, these things can even out even in the very short term. Access. Block time's an issue. You have to find a way to get access to a machine. Everybody wants to be on one. Nobody thinks you should be on one. You must be prepared to fight. You must sit on committees that if you don't sit at the table, everybody's just going to cut you out. You got to sit there and be a pain in the ass. You have to make your case for the importance of emerging markets and how that affects the reputational benefit of your institution. Again, I talked about the enhanced recovery stuff, so I won't go back into that. Patient selection. You have to set yourself up for success. Pick an easy patient first. Don't make it more complicated than you have to be. This was one of my first patients. It was a right-sided mastectomy with a robotic latissimus dorsi. This is before and then after expansion, then contralateral augmentation. This is considered, a home run for reconstruction. It looks like a breast augmentation. Dissemination of your technique. You must publish your results. It's very important to publish your preclinical results because they will be the foundation of your justification for your clinical activity. So publish your lab stuff, even if it's small. You present your stuff at conference, your peers are going to want to see every step that you've gone through, and they're going to evaluate that, and they're going to jump on it if it's not done in the way that I've described. So this is just sort of a summary of the peer review process based on the other things I discussed. This is kind of the court of public opinion. This is the microscope that people will put you under. What's the clinical need? Is there a need, or have you just tried to do something because you can? Do you have the appropriate skill acquisition? Are you virtuosic? Do your videos look good, or does it look like you don't know what you're doing? Have you gotten the appropriate regulatory things done? Is it safe? Is it legal? Is it generalizable to their institution? You have to understand the rules of the game and play by them. Patient selection. Do the people who watch you do what you do they want that for their patients, or do they think that that's not something they would want for their patients? Ultimately, providers want something that they can use on their patients, for their patients. If it's not gonna help with patients, it's not gonna help anybody. This is a short video that you're gonna have to play this from the computer. I have this conversation a lot with people, and I want you to hear it.
I know you're taking the teeth out there. First guy through the wall, he always gets bloody. Always. This is threatening, not just a way of doing business, but in their minds it's threatening the game. But really what's threatening is their livelihood. It's threatening their jobs. It's threatening the way that they do things. And every time that happens, whether it's a government or a way of doing business or whatever it is, the people who are holding the reins have their hands on the switch. They go batshit crazy. I mean,
So this is all of the people who sort of stand in the way of your progress. The people who stand to lose from your innovation is everybody who is not going to be involved in the innovation. I always tell people, and I take this advice myself, never let personal investment in the old ways or what you do stand in the way of progress. If you see this coming at you, get out of the way. Get out of the way, because you can't win. And that's what this is. The train's already out of the station. So you really need to either get on board or get run over. This is from the March issue of PRS. It just came out. Can I make robotic surgery make sense in my practice? It goes through a lot of these issues, a lot of the barriers to entry and how to overcome them, and maybe provides a little inspiration when things get a little boring. So in conclusion, develop a practice it's a multi-stage process. I want to really emphasize perseverance and resilience, and also self-criticism. Look at what you're doing honestly. Does it make sense to you? If you were looking at it, would it make sense to you? It's incredibly rewarding. It's one of the most rewarding things you can do with your career, and it's the future. So just get there early, because it's going to show up at some point soon. So thanks for your attention.